I see Dr. Guimares is on the screen, so welcome, Dr. Guimares.
How are you?
He's an interventional radiologist for, I don't know the exact number, maybe 15 or 20 years. And I know he's also the medical director of the division of interventional radiology um, for the Medical University of South Carolina. We were introduced by a patient down there in Charleston, South Carolina, and Dr. Guimares is doing some exceptional things for patients down in that neck of the woods. So as soon as we get his presentation up on the screen, we'll get him started.
Thank you, Bob. Thank you for the opportunity to be here. Can you hear me?
Yes, we can hear you. We're just waiting for your presentation to come up on the screen.
Sure. I'm sorry for the technical difficulty here. I'm doing exactly the steps that we supposed to be doing. Just give me 1 second, Bob, and we'll get started. I don't know exactly what is the issue.
Yeah, no, we have your presentation. I guess they're just taking a moment getting it loaded here. So sorry for the delay, but I'm sure we're in good shape here. Oh, there we go. All right, looks like we're in good shape now.
Okay, give me just 1 second because I think this display won't show the videos, Bob, and we need to have a specific way to get access. Just give me 10 seconds here, and I will try to get this. We'll make a decision in 10 seconds here. Yeah, unfortunately, what I'll need to do, Bob, is I will have to show the images without the movies.
Yes, yeah, that is what happens on this particular platform.
Yeah, which is okay. I think we still can give a pretty good message here. So good afternoon, everybody. My name is Marcelo Guimares. As Bob introduced, had a kind introduction here. I'm a vascular interventional radiologist at the Medical University of South Carolina. We've been treating patients with neuroendocrine tumors with liver metastasis, primarily liver metastasis, for over 13 years at this point, but I've been doing practice in over 20 years. At MUSC in Charleston, South Carolina, we have the highest end technology possibly available in the world today. And we have a multidisciplinary team in this building where is the Hollings Cancer Center, who has radiation oncology, medical oncology, surgical oncology, and interventional radiology. Ourselves are always discussing patients and trying to identify what's the best for patient care. So the goals of treatment today in 2021 for this type of disease is to try to bring the patient to a disease-free state. So I'll quote unquote, I would say cure, downstage the patient to potentially a resection in case there's a single predominant mass that needs to be resected. The goal is to prolong survival and, of course, control symptoms. That's very important, especially for the people who are symptomatic with metastatic disease, and improve the quality of life. So when we see the patients in clinic, we want to understand clearly if they have symptoms, and about 20-30% of patients with NAT will develop symptoms along the way. I try to understand how intense, how important those are, how much it's affecting their quality of life. Identify the primary tumor that's important, and always try to resect that primary tumor as long as there's no disease spreading the whole body. I think if there's only local regional, only oligometastatic disease, let's say only the liver, that's a perfect scenario where the primary cancer should be always attempted to be resected. Understand if the patient had prior therapies or not. What are the other available options? We always discuss all the options available at MUSC. And what's the patient's performance status? If the patient can take care of themselves, they are physically active, playing golf, going for groceries, or if it's another side of the spectrum, a patient that is basically restricted to a bedside. That's restricted to bed. So that's these are very different types of patients. And also it's important to understand what is the liver reserve. So if the liver function is strong and it still can tolerate a lot of procedures or potential multiple interventions, if the patient has extrahepatic disease or if it's just isolated to the liver, and if it's a functional or non-functional tumor, basically if there's a lot of side effects or symptoms or not. Then among the options from my standpoint in 2021, what we have is surgery is one, is anytime there's a primary tumor, definitely should be resected. Some liver metastatic disease also should be managed surgically. We also have the peptide receptor radionuclide therapy. The Lutathera is the main one today, and I know you have a lecture in the morning about this. And then what is a local regional therapy, which is my specialty, is the blend embolization. We'll talk about that in a minute. Radioembolization, radiation therapy injected in the arteries, and also ablations. Can be either microwave ablation or radio frequency ablation. Doesn't make much difference between the two of them. Both are great. And of course, we also have the work done by our radiation oncology colleagues, the external beam radiation, and our medical oncology colleagues using the systemic therapies. What is important to understand the way we think about at NUSC is that we try to define a treatment strategy and tailor that to the patient, and that can be applied sequentially or in combination. This schematic drawing is just to show that depending on the patient performance status, the associated comorbidities, and meticulous tumor staging and assessment of prognostic factors, and depending on the amount of disease that the patient has, in this drawing here we have just a proposed classification. If the patient has, for example, only disease in one lobe, or a little bit of disease in one lobe and a lot in the other lobe, or multifocal disease, which is the type 3, our approach to the therapy is going to be totally different depending on the size of the tumor and the number of tumors. As you can see in this drawing now, there are several, depending on the patient's type of tumor and staging, there are several alternatives, including here, and again, as I said, from the surgical side all the way to the no invasive, which is, for example, systemic chemotherapy, and Lutathera certainly plays an important role in 2021. This is supposed to be in a slide showing the multiple lesions in the liver. Again, forgive me, I won't be able to show the images that I'd like to, but this is a CAT scan of a patient who had a multicentric, multiple lesions in both sides of the liver, and the goal was to demonstrate, and here are some slices to show large lesions in the dome, as you can see on the right side in the left upper quadrant, and then on the left lower quadrant you can see a hyperdense, brighter. Anything that is brighter here with the liver, you can see the liver in the background with a kind of grayish, and then the larger roundish lesions that are all metastatic disease of neuroendocrine tumors. As you can see, typically the neuroendocrine tumor metastases have a lot of blood vessels, which is a great thing for our specialty because we do endovascular, so intra-arterial therapy, and that's why you see a lot of contrast. That's why it's bright in the CAT scan. For the diagnostic part, we usually use MRI or CT, either one of them. So let's get started with among the liver-directed therapies. Let's talk a little bit about blend embolization. So the blend embolization is basically we get access in the patient's radial artery or femoral artery, and then we deliver an oil. It's called lepiodol. This oil and some particles too. As you can see in this drawing on the right lower quadrant, you can see the catheter tip. And once we get it selectively, we can do an angiogram, inject contrast, and you can map out, understand really well where the nodules are. As you can see in the liver here in this picture on the right upper quadrant, that's the typical angiogram picture. And then after that, we inject the oil and the particles with the goal to starve the cancer from blood work, from blood supply. And starving the cancer from blood is what's going to happen, is going to basically have no viability and is going to die. So that's what we want to do with the blend embolization. As I was saying before, we can do radio access through the patient's hands we conducted a randomized prospective study back in 2016, and we saw that every 5 patients that have radio and had femoral in different procedures, 4 out of 5 patients prefer radio access for multiple reasons that we can talk later on. This is an example of a benefit that the radio access can provide to us, especially in patients who are, for example, taking anticoagulation or aspirin or Plavix. Patients do not need to stop those drugs anymore if we use radio access. Also, radio access is very important in this patient's groin. On the left lower quadrant, you can see that's a picture of a groin of a patient that is obese. You can see there's a lot of soft tissues in the groin versus the amount of soft tissues in the patient's hand. Is the same patient. And you can see how clearly it is safer and better to get access trans-radio versus through the groin. Shifting the gears now from the endovascular to the percutaneous. From the percutaneous standpoint, we can perform liver ablation, again, using radio frequency or microwave. Typically, we do under CT guidance. The right lower quadrant picture shows a CAT scan of a patient, and you can see the bright nodule. That's where the metastasis was. We injected, in this case, contrast in the oil, the thiazole before, and that was excellent to guide us where the lesion was, and you can see we're right on target. We can do this under ultrasound and under CT guidance. This is the type of setup we have in our room. Typically, these cases are done under moderate sedation, but depending on the patient's respiratory and cardiac functions, we might require general anesthesia as well. As I mentioned before, we have the highest technology available in the world today. We do everything under image guidance, including the access. As you can see here, this is a microscopic needle getting access into the patient's hand. This is the patient's hand here on the right lower quadrant. And you can see in the right upper picture, that's the ultrasound showing us the guidance towards obtaining access into the radio artery. So every step of the way is under image guidance. So that provides major safety. Going back to the blend embolization with the lepiodol. Lepiodol is the oil that I was mentioning before, or using particles. Particles look like a microscopic sandstone that are all biocompatible. Both the components, both embolic agents are biocompatible, so there's no problem with the body. It can be injected. And basically the goal in this case, you can see we got access in the patient's wrist. This picture that shows left means that's the patient's left forearm. We're getting access here. And then we travel all the way down to the liver. And I believe you can see in the middle of the screens, or slightly towards the right side, there's a catheter coming from above and injecting contrast. You can see the blush. This blush, especially in the right lower quadrant picture, you can see a blush of contrast that's inside the liver where the metastasis is. And after getting selective access to that tumor, we can see and injecting the particles and lepiodol, cutting the blood supply. This is the final angiogram, this final run, showing no contrast anymore. That blush that you used to see in this corner is no longer seen. So that's exactly what we want, is to cut the blood supply. And typically is required about 2 or 3 sessions to obtain full control. And this procedure can be done as an outpatient, by the way. Another thing we've been doing the last few years to increase the preservation, to preserve the max amount of liver and only inject the particles in the oil where the cancer is. This is the technology that we've been using. I think you can see in the left lower quadrant, you can see like a C-arm that's supposed to be rotating around the patient's body. And this X-ray image is supposed to be showing that machine spinning around the patient that is on the table. And that spin is similar to a computer tomography, right? And that is a fancy X-ray to show to us where we can then track, using a very special tool, we can track what blood vessels are feeding the cancer. As you can see here on the green on the right lower quadrant, You can see that there's one main superior branch and a second inferior branch, both feeding the cancer. And then we can go super selective with a microcatheter, which is a little thicker than a hair, and then block the blood supply of both nodules, blood vessels feeding the nodule. With that, we can preserve, I would say 95, 98% of the liver is preserved, and we're only only killing the blood supply of that small portion. And this is the image pre. You can see here a large tumor in the right hepatic lobe, right side of the liver. This is pre without any contrast. And this you can see here post, the white nodule. The white is the aspect of the thiodol. Anytime you inject that oil is extremely bright in CT, and that's what you see, a very good response post blend embolization. Let's switch the gears now to radioembolization. As you can see here, this is now similar to the blend embolization from the access perspective. So we get access in the patient's groin or wrist. We navigate all the way to the liver. You can see we have a microscopic catheter here on the right side picture. That microcatheter in this case is injecting contrast. You can see multiple nodules throughout the liver. And what we do with the radiation is we inject radiation, as you can see here in these drawings, with the radiations those are 8 to 20 microns in size, and they deliver a very powerful radiation that will kill the tumor and will preserve the liver. So typically the way we do the radioembolization procedure is it is require a 2 or 3 days, different day interventions. If we are going to embolize only one side of the liver, then you have 2 days. Typically we have the workup day, which is what you see here in front of you. This is an angiogram of the liver. We are basically going to define where the tumor vessels are, and then we're going to inject a fake radiation. Basically, is a radiation, a liquid in the liver, to study if that radiation is going to be just stuck to the liver. So we don't want to bring the patient back a week later for the powerful radiation, and that could potentially go to other organs. So we want to make sure that we have a trial, a fake radiation, a simulation first, to make sure that we are delivering the radiation, the future powerful radiation, to the right place. There are some situations when we have adjacent arteries next to the liver that we do not want to deliver the radiation to. And in order to avoid to deliver the radiation to the stomach, pancreas, or duodenum, and then have complications in those organs, sometimes we need to block those adjacent arteries, as you can see here with the coils, with this the brightness in the right lower picture are what we call coils. They're like a spiral, like a curly hair that we inject inside the blood vessels around the liver in order to just direct the flow to the liver, blocking all the peripheral vessels that we can. Somebody could ask me, what's going to happen in case you block the blood supply going to those organs? There's no problem, because there's a second blood supply coming from below feeding those organs as well. So there's no problem to cut the blood supply coming from the vessels that are close to the liver. And then right after we inject the fake radiation and we block any potential blood supply, what we do is we bring the patient back for what we call the nuclear medicine scan. And we call that also a SPECT. So a SPECT has 2 reasons to have a SPECT right after, in the same day of the workup or the first infusion day. What we do is we have the nuclear medicine scan to document how much radiation went from the liver towards the lungs. These drawings here, for example, the red drawing is the liver, and the white, light green is the lungs. So it's important to know how much of the fake radiation will go to the lungs, which is going to give us a sense how much of the real powerful radiation in the following week would go to the lungs. As you can see here on green, it says lung shunting is 2.44%. That's very low. It is a contraindication if it's above 20%. We need to adjust the dose if it's below 20, if it's between 13 and 20%, and if it's below 13%, we inject the full dose. That's what we call SPECT. That's also important not only to understand the shunt, how much radiation will go to the lungs, but also this type of picture can show us if there is activity, the fake radiation somewhere else around the liver. that we could need to go back and redo some more blockage of the arteries that are adjacent to the liver. As you can see here in this picture, there's a low shunt in the last, very low, small amount of fake radiation went to the patient's lung. And also we only see radiation around the liver. We don't see anywhere else around. So this patient is a perfect candidate for the radiation therapy. And then what we do, we bring the patient back in the following week. And in the following week, we then infuse the radiation. That can be in one lobe. We typically do one lobe at a time. And if the patient needs a bilobar, both lobes to be injected, then we give a break of about 30 days and bring the patient then for the infusion of the contralateral lobe. So again, if the patient needs one lobe infusion, is 2 procedures total. If the patient needs to have the radiation therapy injected in both sides of the liver because the disease in both sides, then we perform 3 interventions. Just 1 second. The presentation blocked here. Just 1 second. Okay, and this image is supposed to be showing a procedure of a very close to my heart patient that lives in Charleston, is part of this community that I treated several years ago. And this is supposed to be the angiogram showing what's going on with this patient that had multiple liver lesions. And then we treated with radiation, with radioembolization. He had a partial response. And then this patient ended up, we discussed about what to do after the radioembolization. We proposed to have 3 sessions of blend embolization. And after 3 sessions, basically the goal of this MRI that is here in front of you, but I won't be able to run the movie, is to show that there was no more active disease. And he's been followed frequently, and 8 years later, basically, there's no evidence of disease. So that's a remarkable response. And it was a pleasure to treat this patient that is very close to us. So in this image, this slide, forgive me, but this is supposed to show the lesions pre and post, showing a complete response. This patient had multiple lesions both sides and responded totally. So here is the ablation. That's the setup we have. Usually we use under computer tomography. You can see here the CAT scan. It's very safe procedure. We insert this needle around the nodule, and basically what happens is that needle delivers a sphere of energy, and that sphere of energy burns the tumor. Sometimes, in order to increase the response, and here's a picture of a liver. That's a specimen of a liver resected after the patient's death. You can see that there is a white spot, a very large white spot in the liver. When we see sometimes in the CAT scan on the MRI, we only see this round red circle. But in reality, the tumor sometimes goes beyond that. So that's why we are very meticulous on the margin, to obtain margin of the treatment in order to treat those peripheral areas. So one technique that we have done in the last few years that helps tremendously with this is to what we call the back-to-back technique, which is to perform a blend embolization with the oil first. And then, as you can see here, the nodule in the liver in the upper images, we injected oil. The oil, then we bring the patient back in the next day or in a few days later, and you can see how bright the cancer becomes. And then that helps us tremendously for a perfect targeting. As you can see, the needle is perfectly in the middle now, and this tumor is totally gone after using this. So this is just to improve the accuracy of what we're doing. After the blend embolization or radioembolization or ablation, about 40% of patients can have what we call post-embolization or ablation syndrome. It's characterized by having pain, nausea, and flu-like symptoms. Typically, it's more intense in the first 24, 48 hours. But even though these procedures are done as an outpatient, the patient can go home with medications to treat those symptoms. And typically after 2-3 days, the patients are back to normal. Complications are very rare. Radioembolization, the most common ones are gastritis and ulcer in the stomach. The blend embolization is infection inside the liver. That's why we give antibiotic for several days. And ablation, similarly, is infection and bleeding because of the puncture site. But those are all rare, very rare complications. So we've been building best practices at MUSC in the last 15 years. The plan is the concept is on best practice is to offer radio access for the patient so they can walk right after the case. They don't need to keep their legs straight down for 2 to 6 hours. The Y90, the radioembolization, and the blend embolization can all be performed as an outpatient. We reserve ablations for liver lesions that are up to 3 centimeters, up to 3 lesions, or 1 lesion up to 5 centimeters. We also combine our therapies with Lutathera and also with systemic chemotherapy as needed, with surgery as needed. We use the rotation angiography as you saw the mapping, the colorful mapping of the tumor in order to have a precise medicine, so precise delivery of the radiation. And of course, we have very close surveillance of these patients in clinic. So it's important to understand that the majority of patients have a very good response to our local regional therapies, liver-directed therapies. Nowadays, there's not much evidence to show that if the blend embolization is better than Y90. In my personal practice, I would prefer to start with the Y90 because it does not block the blood vessels. If you start with the blend embolization, that literally blocks the blood vessels, then you don't have the chance to come back to do the radioembolization. So I prefer radioembolization first. If that treats all the tumors, great. If there's something residual, then we do some blend embolizations like we did with that patient that I mentioned before. If the patient is asymptomatic and small of volume of disease and stable disease, we tend to observe and not necessarily be so aggressive. But if the patient shows progression of the disease or has large volume or is symptomatic, we definitely recommend treatment. And again, the resection of the primary tumor to us is extremely important in order to have a full control of the disease. Basically, the concept is if you don't remove the primary tumor, especially from the pancreas and from the small bowel, that is going to continue to send metastatic disease to the liver. Even though you have successful therapy, you're going to have new metastases in the future. So that's why it's so important to resect the primary tumor and work collaboratively with our surgeons. So in summary, the survival is very good overall and depends on multiple factors. The blend embolization or the Y90 or the radioembolization have well-established role in the treatment of neuroendocrine tumor metastases. We always use octreotide, short-acting or long-acting because that has proved a benefit in increasing survival. And we always discuss the patients in a multidisciplinary group in order to provide the best care. That's the best of all, is to see our patients doing well, back to their families, being functional, having good quality of life. That's our mission when we think about minimally invasive therapies. Thanks so much.